This is my COI. We reported 10 years ago the procedure of the poem. So far in our institute, we performed more than 2,000 cases. I would like to talk about the details of our complications. Most of them are minor injury, minor complication, and are 70%, more than 70% is a mucosal injury. Yes, so 2.6%. So mucosal injury as a gastric cardia is the most common. And it keeps the patient fasting and wait a moment. That is the solution. So I will show you, this is a case. So we use a spray coagulation. At the top of the image is a muscle layer and the bottom is a mucosal layer. So at the end of the creating tunnel, so we have a perforation on the mucosa, like this. In a little flex view, we can recognize the mucosal injury at the level of the esophagogastric junction. So following day, we check the position, and we can recognize the wider area or necrosis. This is 2 months after it was recovered as a scar. So when we encounter mucosal injury at the gastric cardia at the time, so closing, try to close it using loop and clips. This is a case, another case. So from the esophageal lumen, we are trying to close a mucosal defect using a loop and the clip technique. So right after closure in the lateral flex view are using a loop and the clips. So treatment for mucosal injury is, if possible, endoscopic mucosal closure we have to apply, but most important is that keep the patient fasting a few days. That is the most important. So next, I'd like to talk about the submucosal hematoma. It happened less than 1%. So this is a case. So following day, at the time of a check, you can see a big hematoma like this. So our treatment option is the careful observation by endoscopy and of course the other parameter of inflammation. So most of the cases are naturally controlled, absorbed. But in the case, just in the case of if it grows, take out the clips, take off the clips, and the drainage in the submucosal space is mandatory. So next complication is mediastinitis. So it's sometimes combined with hematoma, 0.2%. This is a case. Right after procedure, following day, nothing bad. So volume swallow on the following day looks very good. But 3 days after procedure, patient has a high fever, and you can see a big abscess exists. And the day 11, there we can see mucosal defect of the gastric cardia, and the already abscess and the debris was already out naturally. So this is a clinical course. This patient, at the day 11, the patient has a chest pain, and the maybe abscess is open to a natural lumen, and after that, so patient kept a good course. Next, I'd like to talk about mass bleeding. Mass bleeding. So, mass bleeding may happen in 0.2%, very unusual. So most of the uncontrollable bleeding may happen in a gastric side, particularly in the lesser curve of the stomach. So this is a demonstration of the branch, large branch of a left gastric artery going the level of a gastric caldera. So if we make some injury onto this large artery, so severe bleeding may happen. This is a case. This is our third case. Okay. Oh, so video no good, but anyway. So we cut this vessel. We cut this gastric muscle. So at the time, we make an injury onto a very big branch of artery, and the patient has actually had a huge bleeding. Finally, we control it by hemostasis. So what I want to emphasize is that in a gastric side, particularly in the lesser curve of the stomach, there may be sometimes maybe the branch of a left gastric artery. It may cause a severe bleeding. So it would be better to be very careful.
Da ist jemand.
So next, I would like to talk a little bit about the postform GERD.
Wer ist denn der eine Herr, der da unten, wer ist denn der eine Herr, der da unten im Bild ist?
Cases become a severe GERD after a foreign procedure.
Okay, Kostamania, das war meine Sorge, Kostamania ist nicht da. Ist da, gut.
And how to, control it. As you know well, the poem has the high technical success rate, but the 20 to 50% of the cases become the postpartum GERD. So most of them are mild GERD. Anyway, so in order to avoid the postpartum GERD, we recommend the double scope method. So like this way, we place two scopes. So one scope in the stomach, and it keeps a little flex, and they control the gastric myotony rings. Left side, you can see Submucosa endoscopy already reached to the stomach. So areas is a totally divided.
Wir sind 11:08
We can objectively recognize it.
11:16 sind wir fertig zu gucken.
But sometimes without double scope, in order to avoid incomplete myotomy, we cut too much to the gastric side. It may cause the hiatal hernia and the severe reflux. So this is the RCT conducted by the Dr. Kevin Grimes. So he concluded that the gastric myotomy more than 3 centimeter results in increased risk of severe esophagitis. Okay, so once the patient becomes a severe GERD, how to manage those patients? So now we recommend the POEM plus fundoplication. That is a pure nodes procedure. So like this way, we place the fundoplication similar to DOR. We have already published the technique. So finally, I'd like to mention the failure of the POEM procedure. End-stage achalasia is even an end-stage achalasia, we have to perform the POEM. So some of them works, but in some case it doesn't work. So this is our data. So in our hospital, all the patients receives the POEM procedure. And among them, the 3% patient receives a second POEM. So 2 times POEM, that is ineffective. It may happen 0.1% of all cases. They have to receive the esophagectomy. So this is a case of esophagectomy. So first, the patient receives the balloon dilation 3 times other hospital, and the laparoscopic hair procedure 2011, not previous hospital. And then patient receives 2013, the POEM procedure patient received. And the 14th, because the POEM didn't work, so we decided to perform esophagectomy. So this is a patient before POEM procedure, mega esophagus dilated. It's a very small passage of a volume. So CT scan demonstrates widely dilated, very dilated esophagus. We perform the POEM like this way. So lots of fibrosis and very difficult to do the procedure. But anyway, so finally, hiatus is open. So right after POEM procedure, hiatus is open, the right side slide, but and then once becomes a little bit better than before, passage of the contrast media through the esophagogastric junction. But 1 year later, the patient again come back to a hospital with a very, very enlarged esophagus like this way. So endoscopy demonstrate the mega esophagus. We performed, yes, we decided to talk with the patient, and we decided to perform esophagectomy. So like this way, this is a terminal achalasia. So in some patients, we have to do our esophagectomy like this. That is the 0.1% all achalasia patient. But so finally, I would like to show you the very impressive case. The age over 67, the mega esophagus, the stomach was, esophagus, dilated esophagus was filled with lots of debris. And we performed the POEM procedure. So muscle layer was very thick. We have dissected the LES totally using double scope technique. We control the position of the scope. And then, so 7 days after treatment, dilated esophagus recovered. The patient already started the food intake, but esophagus, clearance of the esophagus was good. Actually, patient had some mild esophagitis, but no problem, no clinical problem. So in this patient, coming back 1 year after POEM procedure, the patient satisfaction was very high. Eckert score improvement 0. So that means the patient is a perfect control. So ladies and gentlemen, this is my summary of this presentation. Complications of the POEM, we don't have any life-threatening complications. And the minor complications we have 3.4%. So all of them are conservatively controlled. 2 patients becomes a severe GERD, and they are treated by, yes, first we perform the arms, but now we recommend the POEF procedure because patient esophagus has no peristalsis because of achalasia. So failure of the POEM, that may happen 0.1 to 0.2%. They should be treated by esophagectomy. This is my summary. Thank you very much for your kind attention.